All right, thanks Libby for starting the recording. Hi everybody, my name is Amity and I'm the director of the National Ombudsman Resource Center, and we're glad to have you here today. I'm leaving this slide up for a couple minutes and then we'll get into more of the introductions. But if you could please take this pre-test survey, either scanning the QR code or using the link in the chat, and I'll drop it in again for those of you that may have joined after I put it in the first time. If you could complete that, that would be really helpful for our presenters to get an idea of your knowledge both before and after the presentation. So while you are filling that out, I'll go over some of the housekeeping. As you can see on the slide, this session is being recorded, and hopefully you heard that as you joined. All lines are muted currently, so please ask your questions using the Q&A box. You can use the chat feature when you are responding to questions from presenters, or responding to questions from your peers or sharing some examples or experiences, but really encourage you to put your questions in the Q&A box so we don't miss those for the presenters. All right, so please complete that pretest if you haven't already. And Libby, you can go to the next slide. Thank you. So hi again, and welcome to our Mental Health 101 Suicide Prevention and De-Escalation Strategies webinar. We are very, very pleased to partner again with speakers from the Center of Excellence for Behavioral Health and Nursing Facilities, or you could call it the COE-NF. The COE-NF, established by the Substance Abuse and Mental Health Services Administration, or SAMHSA, in partnership with the Centers for Medicare and Medicaid Services, CMS, provides mental health and substance use training, customized technical assistance, and comprehensive resources to certified Medicare and Medicaid nursing facility staff who care for residents with a variety of behavioral health conditions. All of the training and resources are provided at no cost to the facility. Hey Libby, could you check, can you hear my audio? Because I see someone in the chat said they can't. Nikki, can you hear me?
We can hear you.
Great, okay, thank you. The primary audience for the COE-NF trainings are nursing facility staff. However, we think it's really important for ombudsman programs to hear what they are hearing so you can share information with them and the best practices you learn. So today we're going to be talking and learning about common mental health disorders among nursing facility residents and best practices you can share with nursing facility staff to better support residents. Next slide. So some brief housekeeping materials. I know I already talked a little bit about them, but again, webinar is being recorded. Please use the Q&A feature for questions for the speakers. You can share information or respond to questions from the speakers in the chat feature. At the very end of the webinar, an evaluation questionnaire will automatically pop up when the webinar is over. Please complete that. And yes, the webinar materials and recording and everything will be shared with all registrants following the webinar. So now I would like to introduce Nikki Harris. Next slide. As you can see, there's a more comprehensive bio on this slide for your viewing, but I do want to let you know that Nikki serves as the training and education lead for the Center of Excellence for Behavioral Health and Nursing Facilities. For the past 20 years, Nikki has provided program implementation, development, management, external and internal trainings, policy development, quality assurance, and managed training coordination and technical support throughout the Southeast region. She has a BA in psychology from the University of South Carolina, an MA in counseling from Webster University, and is a certified behavioral specialist. I have had the pleasure of working with Nikki on several webinars, so I'm really glad that we're doing this again. And Nikki, I'll turn this over for you to introduce Brian.
Good afternoon and welcome again. I am Nikki Harris, Training and Education Lead for the Center of Excellence, and we are truly excited to partner with the National Resource Ombudsman Center to host our training today, Mental Health 101, Suicide Prevention and De-Escalation Strategies. Now, I am happy to introduce our presenter for today, Mr. Brian Stevens. Mr. Stevens is a licensed professional counselor and the founder and CEO of Talk Forward, which provides psychotherapy and executive consulting services. Brian has practiced in behavioral health for the past 30 years and has extensive executive management experience. He recently served as the president of the Licensed Professional Counselors Association of Georgia, LPCA, which has over 8,000 members. Now I'll turn it over to Brian to begin the presentation. Thank you.
All righty. Well, I've had a mouse failure right as it's time for me to be able to control the slides. So I will say next slide. Okay. Well, welcome to Mental Health 101 and de-escalation and suicide prevention. What we're going to be doing today is really look at what is mental health, what is mental illnesses that we are likely to see in different homes. And we're going to define and discuss common mental health disorders in nursing facilities, discuss causes contributing to the onset or exacerbation of symptoms, look at awareness for suicide prevention, and identify helpful de-escalation strategies for staff that they can use to support residents with mental health conditions. Whoop, I got my mouse working again, sorry. I will also just very quickly say it is ragweed season, and so if I clear my throat, I apologize. So what is mental health and why is mental health important? When we think about mental health, what we're thinking about is the health that involves a person's psychological, their emotional, and social well-being, right? So it shapes how we think, how we feel, how we behave, how we react, and how we're able to socialize with others. It also determines how we're able to manage and handle stress and those events that come up in life, and how we relate to others and make choices. Just like physical health, our mental health is important, and it's important to us across all of our lifespan. So this is something we want to look at with everybody in every age group. And I like to distinguish a little bit between mental health and mental illness in the same way we would think about the difference between physical health and physical illness. So mental health involves the effective functioning in our daily activities. When we're mentally healthy, we're able to be engaged in our productive living activities, working in our communities, being able to be a caregiver, having healthy relationships, and of course, an ability to adapt, to change, and to cope with adversity when it comes up. If our mental health is poor, these areas suffer. When we talk about mental illness, we're referring to a diagnosable mental disorder, and it has the following effects, right? Significant changes in thinking, feelings or emotions, and our behavior, distress or problems functioning in social, work, or family activities. So a good example might be somebody with depression might be able to function at work, right? They might be able to summon the energy to function at work. But they're kind of spent and they come home, and the depression primarily then impacts their ability to engage in family activities. I want to take a moment to address some of the common myths and misconceptions about mental health. And I think these are really pretty pervasive, and while stigma has gotten better, we still run into these, and we really need to be able to address them if what we're going to do is be able to work with people with mental illnesses in a compassionate way. Some of these myths that we have are people with mental illnesses are crazy, that mental illnesses are extremely rare. They're just not that common. People with a mental illness cannot function in society. Mental illnesses make people violent. And may be the worst. You can't get better if you have a mental illness. The facts are frankly quite different. Let's start with the scariest one. Most people with mental health problems are, in fact, no more likely to be violent than anyone else. When we look at people with mental illness, only 3 to 5% of violent acts can be attributed to individuals living with a serious mental illness. And remember, we're looking at mental illness as something that's affecting thoughts, feelings, and behavior in a way that disrupts one of the domains of living. People with mental health conditions are just as productive as other employees, and they can be just as engaged as family members. They can be just as good in their communities. People with mental health conditions can get better. Many are able to recover completely. And we think about recovery coming from the substance abuse population, right? It's the process in which people can live, work, learn, and participate fully in their communities. And when we think about mental illness as being rare, the National Institutes for Mental Health estimate that in the United States, 1 in 5 adults will have a significant mental illness within their lifespan. That is, having a change to their thoughts, feelings, or behavior that interferes with one or more of their domains of living. 1 in 5. Right? So if we think about those numbers, the reality is people struggling with poor mental health, people struggling with mental illness is quite common. And it's one of those things that most people don't notice. So let's talk a little bit about the common mental health disorders in America. And we're going to spend a little bit of time here. The generalized anxiety disorder, or anxiety disorders in general, are often characterized by people looking to the future and being worried about different negative outcomes. Anxiety often results in kind of increased sense of thinking about things all the time. You can have a sense of being unsettled, agitated, out of control. Anxiety often can extend to being worried about how we're going to function in social settings. We've seen a lot more social anxiety since we had the worldwide shutdowns of 2020. A lot of people really found their social skills atrophied and are now still struggling to get back to where they were. If somebody's anxiety is bad enough, they can have anxiety attacks or panic attacks where their fight or flight mechanisms in their brain are activated and they really feel under mortal threat. We also can see with anxiety some people with obsessive compulsive disorder. And this is where the person has obsessive thoughts that engaging in compulsive behaviors settles those thoughts down, at least for a little while. Unfortunately, this is one of those things untreated where the obsessive thoughts tend to get worse and worse. And of course, something like PTSD falls under anxiety disorders, where the person is having trouble integrating an existing trauma. I think anxiety disorders are probably one of the most common types of mental illness that we see today. And it is something a lot of people suffer with kind of quietly, but there really can be helped. Major depression then, or major depressive disorder, is a type of mood disorder. And this is a very common amongst mental illnesses, and it is characterized by having a very low mood. The person may have a sense of sadness, or they may have no feelings at all. It's very common for me to see when I work with people having a depression that's really kind of suppressed all of their feelings altogether. So they don't feel negative feelings, they don't feel positive feelings, they just feel kind of gray. We generally see somebody's sleep is disrupted. Either they can have an agitated depression, so they have a decreased sleep, or a more vegetative depression, where the person has excessive sleep. Often you see low energy, lack of interest in pleasurable behaviors or pleasurable activities that they used to enjoy. So maybe they're just not interested in hobbies. They're not interested in things they used to read or watch on TV, or even engaging with other friends or family. Depression, of course, is one of the disorders that we have related to suicide because of the hopelessness and the helplessness that can go along with major depression. One of the things that we can see with depression, if somebody's starting to come out of major depression, is we do want to watch them, because they may still have the hopelessness that makes them suicidal, but now they have more energy to do something about it. So that can be one of the things we want to look at with depression. Generally speaking, we look at if somebody has a major depressive episode, their chances of having another major depressive episode are about 50% across their lifetime. If they have two, 75% that you'll have a third. If they have three, probably the probability of ongoing depressive episodes is about 90% or so. That's untreated. Moving from major depressive disorder, we'll talk about bipolar disorder. This, of course, used to be called manic depression. And this is when somebody alternates between either depression and mania or depression and hypomania. Talking a little bit about mania and hypomania. So mania is that full-blown high-energy mania. Hypomania is a lower level of energy. So let's talk a little bit about that. When somebody's fully manic, kind of at the opposite end of depression, they very much will engage in behaviors that are often excessively pleasurable. So they're more likely to use drugs, alcohol, sexual behavior, gambling, shopping, anything that gives them that sense of pleasure. Often with full-blown mania, people have a tendency to not need sleep at all. This can lead to psychosis, because any of us go long enough without sleeping will become psychotic. You can have delusions, generally a very high level of energy, racing thoughts. Often full-blown mania can feel disruptive to people, because one of the things that happens is things are too fast. I've got too much going on in my head. I can't get my thoughts out. I can't be controlled. Hypomania, which is a step down from mania, actually feels pretty good to most people. They may be a little bit more irritable, but you have somebody that have more energy. They feel more productive. They feel more creative. They don't need as much sleep, but they're still getting some sleep. Again, may engage in those more pleasurable activities more than they would otherwise. So you may have an increase of sexual libido, more drinking. And thoughts come quickly, and they really feel productive and get a lot done. The problem, of course, with hypomania is your brain can't last, and eventually either you're going to crash into depression or jump into full-blown mania. But it is the existence of the hypomanic state, which is one of the things that can make people with bipolar disorder reluctant to stay on their medications, because it does rob them of the hypomania, which is really a state that they like. And who of us wouldn't like to have not need as much sleep, have all the energy we need to get everything done during the day, feel creative and productive and engaged. Now, there's a third state with bipolar disorder that is a mix of depression and mania, which is called a mixed state. And this actually can be a pretty dangerous state, because one of the things that we see in the mixed state is the person has maybe the mood of depression. So they don't have the euphoria of mania. They've got the low mood of depression, the hopelessness, the worthlessness, but they have the energy of mania to go with it. So kind of as I was talking about with somebody coming out of major depression, this mixed state can actually be somewhat dangerous, because what it does is it creates it creates dynamic where the person may not feel good, but they have the energy. They have the energy to get do something about it. Now, one of the things I've seen with bipolar disorder is medication generally is one of the things that really helps. This tends to be a lifelong illness, and so working with a provider to have the right sort of medication for somebody is important. One thing that you will often see if somebody's been really manic is that person may have kind of a higher level of medication to start with, and then over time, as the mania gets under control and the person gets normalized, you might see some of that reduced. Substance use disorder then is obviously big in the news today. We still see a lot of this with the opioid epidemic. And one of the things about the substance use disorder that in my experience is there's usually something else going on. And if we think about it, that makes sense. Why do we use substances? We use substances because we want to change our thinking, our feeling, and behavior. And probably most of us here today used a substance to change our thinking and our feeling, and that's caffeine, right? So those of us that imbibe caffeine in the morning take it to pep us up, to make us feel better, to make our mind sharper. So that's using a substance. Now, it's not a disorder because it can be controlled. Now, when we talk about substance use disorder, people are using those substances to change their thinking, their feeling, and behavior in some way, shape, or form. And this usually then is to cover up something else. I'm anxious, so when I drink, I'm not as anxious. I have some sort of emotional trauma or pain. I take a painkiller, which not only helps physical pain, helps emotional pain. So what we find with substance use disorders is often there's an underlying issue that needs to be addressed, and it's addressing that issue that helps the person get off of whatever substance you're using and get back into some sobriety and stability. Schizophrenia is what I think of as the granddaddy of mental illness. And when people really think about mental illness and people being crazy, a lot of times what they're thinking about is somebody who's having a psychotic episode of schizophrenia. Schizophrenia is a global mental health disorder. It's considered a thought disorder, and it really does impact kind of the whole functioning of the person. Often what we see with schizophrenia is people will have hallucinations. I think hearing voices is probably the most common understood symptom of schizophrenia. People can have visual hallucinations, and in fact can have hallucinations in any category, any sense. I had one client who had tactile hallucinations that duplicated some of the abuse that she had as a child. People with schizophrenia also can have significant difficulty reading other people's affect, and their own affect might be very flat and monotone. Of course, you have delusions as part of schizophrenia, delusions of persecution, paranoia, ideas of reference. You can have, in more extreme cases, disorganized thinking and people that are just not able to take care of themselves because their disorganization has gotten high enough. Lack of motivation and difficulty functioning. So this is a pretty significant illness, and one that absolutely needs medication to help the person kind of get back to as normal as possible. And lastly, we're going to talk just very briefly about neurocognitive disorder. And what we're talking about here is when we talk about today, people talk about being not neurotypical or neuroatypical. We see people, being on the autism spectrum, and the person who is that we see coming in who's having a distortion to their, well, it's not really a distortion, it's just their brains think differently than normal. And so these people often have difficulty reading other people's emotional states, kind of like we just talked about somebody's schizophrenia. Their own emotional state may be difficult to determine. They may struggle to understand instructions presented in a certain way. And so that's something that really, as a society, I think we're coming to grips with in a different way. So what are the prevalences of mental health disorders within nursing homes? What are we expecting to see? Well, the National Institutes of Health estimated that between 65 and 90% of nursing home residents have a mental disorder, right, ranging from common mental health problems like anxiety and depression to more serious mental illnesses like schizophrenia and bipolar disorder. And I like to just think about that number, 65 to 90%, right? So on the low end, that's still 2/3 of the people that we're serving. And on the high end, it's basically everybody. What this says to me is that treatment of mental health, assessment of mental health, monitoring of mental health is not something we do for a small part of the people that we're taking care of in a nursing home. It's the standard for people that we're taking care of in a nursing home. The people that do not have a mental health disorder are in the minority. So this should be part of what we do up front with everybody. So the most common mental health disorders that we see in nursing homes, we see depression and anxiety and bipolar and schizophrenia, right? And so what is it that we need to look for when we look for depression in a nursing home? So I think when the person is, we're going to see people that are sleeping more than they used to, have people who maybe seem to be less engaged. They don't want to participate. You may have some increase in irritability, a change in appetite, expressing symptoms of saying that I'm hopeless, worried about the future, and increased isolation. With anxiety, we are likely to see increased agitation. The person may not sleep as well as they've slept. They may have, you may see pacing, sometimes asking the same question multiple times. So they may be trying to take care of their anxiety, answering the same question multiple times. You may even see anger, because anger can be a response to anxiety. Increased behavior that may require some degree of de-escalation to go with it. Often what we're going to see expressed with anxiety is just a sense of that the person cannot get settled. With bipolar disorder, of course, bipolar disorder is going to express itself as a swing between depression and either hypomania and mania. And this is not, it's not that you swing rapidly throughout a day. That's that you have an unstable mood. But you see that you can have a swing in mood from depression, and then over several days, over several weeks, maybe an increase in mood, and you get the elevation. And what are we going to see in mania? So in mania, right, the person may have rapid speech. They may have almost tangential thinking where their thoughts are bouncing around. They may be able to not, their speech may be so kind of pressured and fast that they can't seem to get their thoughts out. They may even say they can't get their thoughts out, or they may say, yes, I'm having racing thoughts. One of the other things that we look at, of course, with mania, as we mentioned before, sleep. I may not sleep as well. They may not be sleeping at all. They may have excess energy, pacing, increase in sexual activity, or wanting to do other things that are pleasurable. And that would be kind of the sign of the mania. With schizophrenia, if somebody is having issues with schizophrenia, of course, we talked about that person's affect might get very flat. They may have trouble reading other people's affects. They may start acting like they're hearing something. Sometimes, I don't know if you've ever talked to somebody who's hearing voices. They may seem very distracted. And of course, you think about it, how hard is it to carry on a conversation if what you're hearing are other voices in your ears? They may actually be talking back to voices. You might see them staring into empty space. Sometimes they'll get very interested in certain things. I've seen numbers can be very important to somebody who's having delusions, including like lot numbers on medication. I've seen that happen significantly in inpatient settings. What we want to do with any of these is we want to respond with compassion and patience, understanding that what's going on with the person is not a personality defect, it's not a character defect. This is a mental illness that's causing a change. In the same way, for instance, a UTI might cause somebody to have delirium, or you could have steroid-induced psychosis. The person is struggling, and we want to be able to be compassionate and not blame the person for the mental illness. So some of the factors that impact mental health and the nursing home residents, and this is kind of why I think actually 90% of the people in nursing homes probably could get a diagnosis, at least at some point. Being disconnected from a family or a community. If we imagine I live in a community, I'm happy to live in my community. What's it like to not be in it anymore? Chronic pain, can certainly make depression worse. Of course, depression can make pain worse. We can be grieving a loss in loved ones. We can be grieving a loss of physical capacity, our decreased independence, right? I don't have the independence I used to have. Our physical activity is going down. We can't function. We can't work as well in society. Combine that with a potential decline in mental capacity, increased social isolation, and these are triggers for depression. And I have to think, for me personally, right, the idea that I may well, right, this is it, this is the rest of my life, is going to be living in a facility, not in the house I paid for, right? That past life of independence is behind me. And I think we can see why, we are most close to 90%, because this is pretty, this is pretty devastating for us when we move. So as we talk about depression, let's talk a little bit about suicide. Because suicide is perhaps more closely related with depression than any other mental illness in people's minds. So one of the things we know about suicide is it is in fact a leading cause of death, but it's something that's preventable. What I have seen over the years is that, generally speaking, the moment that somebody acts to kill themselves, they're in an acute moment of crisis. And if we can get them through that moment of crisis to the other side, they're relieved to still be alive. So we're going to talk a little bit about some of the warning signs you might be able to see, so that you're in a position, right, to increase the safety of residents. Now, most people with depression do not die by suicide. And major depression and other mental illnesses increase the suicide risk compared to people who don't have depression or don't have a mental illness. And the risk of death by suicide, right, might in part be related to the severity of the depression or the illness. So when we think about suicide, a lot of times when we think about suicide, we think about, I know I had tended to think about adolescents and young people, and we worry about teenagers. But the reality is, older adults have some of the highest risks for suicide, right? So older adults are only 12% of the population, but 17% of the deaths by suicide. And part of the reason for this is older adults tend to plan more carefully, they tend to not tell anybody, and they tend to use highly lethal means. And to put that into perspective, for all adults, right, there's one death by suicide for every 100 suicide attempts. For older adults, that number drops to 1 death by suicide for every 4 attempts. So we go from a 1% death rate to a 25% death rate. That's how much more effective older adults are when they choose to take their own lives. And, we look at this, the American Journal of Public Health looked at suicide rates of people 50 and over, it puts me into that group, living in the community versus living in nursing homes and assisted living. The community rate was 15.66, and the long-term care rate was 14.16. So not a lot of difference that you're inside a facility. So what are some of the risks for suicide? Well, having a mental health or substance use disorder is very high. Many people who do kill themselves at that moment are often under the influence of a substance that decreases their inhibitions. Previous suicide attempts are a risk factor, no matter how long ago they were. And this is because thinking about suicide, contemplating ending your life, is actually a coping mechanism. When somebody feels hopeless and they struggle, the thought that the pain can end is comforting to them and actually can make them feel better. So contemplating, fantasizing, thinking about suicide can make you feel better. What we know is that once we have a coping skill in our tool bag, we never let it go. So if we know somebody has had previous suicidal ideation or previous suicide attempt, that's a risk factor to pay attention to. If a person's expressing feelings of hopelessness, this is huge. It takes 2 things in order to decide to end your own life. You have to both be hopeless that the future will not be any better, and you have to not be afraid to die. This, by the way, is why our military and paramilitary professionals, like police officers and other first responders, are at increased risk of suicide. I remember there was a commercial, it was probably a decade ago or so, but it showed Marines running towards the smoke and the fire and the shooting. We train our military and paramilitary individuals to run to danger and be fearless. What that means is if they become hopeless, they have got the complete equation that they need to seriously contemplate taking their own lives. Of course, having a major physical illness is a suicide risk, and most of us here probably thought, man, if I had a certain diagnosis, I might consider wanting to control how I left this earth. So that clearly is a factor. Not having social support, having a significant loss, financial, relationship. I lose friends, I lose freedom, I lose housing. Which, of course, if we think about it, physical illness, lack of social support, significant loss, all pretty much go with coming into a residential facility. Of course, easy access to means, weapons, medications, other common items found in an environment. Like, for instance, something as simple as a bell cord could be used by somebody to hang themselves. You may see use of chemicals. If somebody's really determined to try to kill themselves, they can become very creative and innovative. What are some things we want to watch for then? So expressing feelings of hopelessness, helplessness, loneliness, worthlessness, a change in the person's religious interest. Maybe it goes up, maybe it goes down. But it seems sudden. It's like, boy, Brian used to really be interested and he did his Bible study every day and he suddenly stopped. Or Brian's gotten very interested and he's going around reading passages out of the Bible. That's different. What's going on? The person may be have anger or irritability that doesn't make any sense. It seems unexplained. People could express a fear of becoming a burden. Oh, it'd just be better if I'm going to be here. I'm such a burden for my kids. It's costing them so much money for me to be here. Unexplained changes in appearance, eating, sleeping. Maybe they just stop taking care of themselves. Starting to give away prized possessions. If you see somebody starting to acquire access to means, right? Maybe they get a weapon. Maybe they start hoarding medications. Maybe there's other items in the environment that they're looked to get a hold of. And of course, experience a significant life event that was negative and not wanted, like the loss of a loved one. Of course, there may be some passive things that people do, right? It's harder to get different things to hurt yourself in a community. There's staff around. Of course, giving up and wanting to be dead. You know, we think about a population who may have physical frailty. Those people just flat giving up may really accelerate their death. Staying in bed, keeping away from others, that just excessive isolation. I'm not going to do anything. Of course, not eating will eventually kill you. And so somebody easily could say, I'm just going to stop eating. The lack of self-care, not taking medications, not adhering to rehabilitation regimen. Of course, one of the things of not taking medications I've seen people do is cheat their medications and hoard them. So later they could attempt to kill themselves with an overdose of their medications. So what can we do when somebody's suicidal? Well, we can take action, right? Start a conversation with the individual, right? I've noticed changes that are happening in you. This is what I'm seeing. I'm worried about you. This bothers me, right? I want to make sure that you're okay. Ask them if they have thoughts about suicide. It's a myth that you can implant the idea in somebody's head. If they're thinking about it, they are thinking about it. And I've been startled with how often when I've asked somebody about suicide, how much if they're truly thinking about it, they'll tell me. And we want to start trying to give that person hope. Hopelessness and not being afraid to die are the two keys. If we can address the hopelessness, the person's going to have less hope or more hope. There's people who can help. We've got resources we can put together. Who is somebody that you have to live for? These are things that we can do to help get the person through this acute suicidal crisis. Generally speaking, we want to promote everybody's mental health, not just people who are feeling suicidal. And that, I think includes if we can get them to participate in group activities. We're social creatures. I've come into a facility. I want to be better engaged with the people around me, or I need to be better engaged because I don't have my old social activities and connections. Keeping people physically active, even if they have to use a mobility device. Physical activity is key to good mental health. We are not just a brain running around in a body. We are a whole person. visits with friends, visits with family, helping to socialize with the residents when it's appropriate, not just getting them to socialize with each other, but can staff help lead the way and get them engaged? And of course, I'm a big believer in music and storytelling, especially if we start to, as our brains have some sort of neurological problem. What we've seen, science shows, is music and storytelling can be very powerful in activating those brains. Okay, so we're going to wrap up talking a little bit about de-escalation and kind of the basics of de-escalation. So to start with, what are we talking about when we say de-escalation? Well, what we're wanting to do is reduce the intensity of a conflict or a potentially violent situation, right? So we want to be able to stop, really kind of stop things becoming physical before they do. It's important in de-escalation to maintain a level of calmness in this stressful or volatile situation, right? Because that reduces the likelihood of harm or violence. The reality is, right, we can't out-escalate the person, right? We can't get into an escalation battle because that might not be winnable. The other person might escalate further than we're able to go. We look at kind of 4 de-escalation skills, I think, that are important. Nonverbal. So this is our, if we think about it, this is our body language. And this gives us the opportunity to convey to somebody that we're not threatening. Paraverbal, which is, I kind of think about, it's the wrapper that our language is. So whatever it is that we're saying, it's how we say it. There's a big difference between keeping a calm voice, speaking to people gently and patiently, than it is to be issuing them orders. We want to engage in active listening, and active listening is hard. It takes work, especially when we have something we want to say. To actively listen, we have to hear what the person's saying and make sure that they understand we understand them, right? So there can be paraphrasing back, repeating things back to the person, being able to say, if they say something that's difficult, that sounds very difficult. That must have been stressful for you, right? Or this may hurt you. And I understand that. Building rapport, Nami talked about this in 2018. Building rapport is really critical because the reality is it's easier to de-escalate somebody that you know and who knows you, that you already have a relationship with, than it is to somebody that you don't know. Right, so we want to, I think, number one, then, know the resident. If you can learn 5 things about the residents that you work with, right? What's their kids' names? What's their favorite food? What's their favorite activity? You know, whatever it is that you learn, it's 5 things about the person that you know that you're able to share and work with them, right? It almost always can help you de-escalate the person. It can help you distract the person because you know something they're interested in. We might be able to distract them. We might be able to get them calm. So we think about kind of the best practice of de-escalation. Ultimately, what does that look like? I think we start with ask about and listen to their concerns. And I think that this is really key. We want to do it in a calm, and we want to speak in a monotone voice. But to me, this is where it's really key. I've served with at different times with both an inpatient behavioral health facility under me and residential facilities that rolled up to me. And that meant when there was a critical incident, I got to sit in on the postmortem and the review to find out what happened. And it became very clear to me as I reviewed a bunch of these, was that when we had an escalation incident, when somebody really started to get out of control or got out of control, when we went through the history, there was an opportunity to see that that person was becoming agitated before we got to the crisis situation. Staff just hadn't noticed. If we can look at somebody starting to get agitated, if we can see what's going on and find out why they're getting agitated, why are you upset? We can make a huge difference generally in the process, right? So the sooner we can get to somebody before they've escalated themselves, the less work we've got to do to de-escalate them. I think we want to remember often what's going on in an escalation is the person has got a need they are trying to get met. It's not getting met, and they are reverting to a more kind of early or primitive coping mechanism to try to get their need met. Because as we all were at one point, the way we got our needs met, I'm hungry, I don't feel good, was we cried, we made a fuss until somebody came to take care of us. And if you think about it from the position of a resident, I'm kind of robbed of a lot of the ways I've had in the past to take care of myself. So we want to answer any questions, right, the person's got about the situation. We're talking to them, what's going on? Is there something you need to know? Information is power. It is amazing how much calmer people are when they are simply told what's going on. Think about it just think about it in yourself. If you're on an airplane's just sitting on the tarmac, it's more frustrating when you don't have any idea what's going on. If the pilot comes on and says, hey, we're about 4 planes back, it's going to be 20 minutes before we can take off because we're taking off from, this busy airport, than if you're just sitting there with no answers. So answer their questions, give them the information. If you need the resident to do something, be polite about it. Polite about what you would like him or her to do. Well, let's come over here, kind of out of the middle of the day room so that everybody else isn't hearing your business, right? Let's go talk over here in private so I can address what's going on. Can we give them choices, right? What can I do to make you feel better? If people have choices, they have power. If they have power and they have agency, that's a way to help them de-escalate because they're partially getting their needs met. They're getting a restoration of agency. And ideally, it's kind of like I, have raised 2 children. You always kind of are doing that line as a parent where you want to give them the maximum amount of agency and responsibility they can handle. I think the same is with our residents. Now, and like children, that line can move from day to day, maybe from hour to hour or across the day. Don't take the interaction personally. This can be difficult because they might be wanting to make it personal. But the reality is they're in the inferior position from a power structure, and it's up to you to meet them more than halfway. Let's not take it personally. If you're really having trouble with that, tap out and get somebody else to help. And speaking of tapping out and getting somebody else, right? If you're not really familiar with a resident, is there somebody who is? Is there somebody we can bring in who really knows the person and is able to work with them? I think that can all be kind of a key thing to get that person back. We want to calm them down and get them comfortable. In general, we kind of look at some key treatments for mental illness, and they depend on the severity, what gets included or not. Whereas individual therapy can be very powerful. I find this is a great way to help people with their mood disorders, with their anxiety, to really kind of understand the roots of what's driving those things and have some control over them. And even if somebody is 85, that doesn't mean it is too late to address something that may have happened to them when they were 5, and that maybe they've been carrying around all of this time, as a way of being that they could let go. Group therapy is very powerful in that you can have people who have similar symptoms be able to support each other and work together. Medications, I think, are really key. Certainly with something like schizophrenia and bipolar disorder, medications are pretty much a must to help the person. I think they can be pretty critical in depression. If the depression's really deep, medications can really help the person feel better and be able to have the wherewithal to work on their issues. Psychosocial interventions are fantastic when we want to be able to help people learn new skills or relearn skills that they've forgotten. Peer support and recovery support groups are great peer-led functions where people can work with each other without having to have the professional there to be able to share and build and develop coping skills together. There are federal requirements to maintain mental health services, which makes sense, right? Because this is the norm, like we saw, 65 to 90% of residents. So we need to have training programs to ensure staff at every level of care have an understanding of mental illness, right? So this isn't just, oh, it's the clinical staff. It needs to be everybody, right? Because who's out there with the residents most of the time? They need to be able to recognize what's going on. There needs to be a comprehensive assessment of each resident's mental health needs and a person-centered care plan to address each resident's specific mental health needs, right? So we want to know what's going on and we want to be able to address it. And assessment is not just something, right, that we do when they come in and we never do it again. That needs to be an ongoing assessment of the person's needs. It needs to be done because if we don't do that, they're going to change. We're going to miss it. We want to make sure that they're getting the appropriate services based upon that assessment and based upon those reassessments. And as I said, right, we want to maximize independence. Why do we want to maximize independence? Well, from a federal standpoint, because it's a human right. It's also, right, it maximizes their agency. When we have agency, we have freedom. When we're able to match the responsibility that we have as a human being, right, that allows us to have as much self-actualization as possible for us in that moment. So I'm a big believer in that. And that one may be the hardest one to do because it means we have to risk the person failing. But it's just as important to let somebody else maybe fail a little bit, right, than as it is for us to have that opportunity. So I think these are really critical things in order to be able to maintain good mental health services. And this is what the requirements are. So isn't it nice when we have requirements that actually match up, which is what the right thing to do is. It's helpful to know what resources are available. So, this national crisis line 988 has come out. So this is a way that people can easily get help. They don't have to remember some 800 number. There's a crisis line that you can call and immediately get some help. You can text home to 741-741. The National Alliance for Mental Illness is a wonderful resource. They are willing to help support, to educate, to provide training. They're good at supporting families. So these are, not only good for you, it's good to be able to refer family members to NAMI when they have of residents. And of course, there's the Veteran Crisis Line that you can call. And with that, I'm going to turn it back over to Nikki. Thank you.
Wonderful. Thank you, Brian, for presenting today's training. And thank you, Amity, and all of the National Resource Ombudsman Center's team for partnering with the COE for today's training. We thank each of you for attending today's training, and we ask that you share your feedback by completing the post-knowledge survey. You can scan the QR code on the screen or use the link that will be placed in the chat for you. It is the post-knowledge survey. Everyone who completes the post-knowledge survey will receive a certificate of completion. This grant is sponsored by SAMHSA in partnership with CMS, and your feedback is truly appreciated. So let's check. All right. Thank you so much for adding the link in the chat. And we also invite you to join us for our upcoming training in recognition of National Recovery Month, entitled Understand the Science of Addiction and Recovery, on Thursday, September 19th from 2 o'clock to 3 o'clock p.m. Eastern Standard Time. The link will be placed in the chat for you to register. Again, that title is Understand the Science of Addiction and Recovery, on Thursday, September 19th from 2 o'clock to 3 o'clock p.m. Eastern Standard Time. This training is being held in hopes of educating all of our attendees on the fact that addiction is a true medical diagnosis. So many people have the assumption of believing that it is a moral failing. And so we're hoping to educate everyone who's in attendance on the true science around addiction, as well as have two individuals who are living a life of recovery, and they will be speaking briefly on what that journey has been for them, recovery, and tips to support anyone who's actually striving to live a life of recovery regarding any subject, right? The principles can be applied across the board when you're looking to make self-improvement and healthy choices and decisions for your life. So again, we truly hope that you can join us. We invite you to that training, and we are so grateful to have had the opportunity to partner with Amity and her wonderful team. It truly is a pleasure. I'm so excited that we've had the number in attendance today. This is phenomenal. Thank you all so much, and I will pass it back to Amity. Thank you so much.
Thank you, Nikki. Thank you, Brian. Amazing information and presentation style. Thank you so much. I think by you moving so thoughtfully through all of your content, it really gave us a chance to absorb and process what you were
Well,
sharing.
good. Thank you.
So thank you.
I enjoy it. I've been at it for over 30 years, and I'm very passionate about the subject material. And I did 25 years in community mental health, so just all very near and dear to my heart. I love the, you know, that doing this is important to me because I want to make sure that the people are getting what they need, and I know that the folks that we have working in these facilities um, are really thirsty for this sort of information because they want to be able to give the people in their care the very best care that they can give them.
Absolutely. So I have a few slides to cover, and then we do have time for Q&A because the webinar today actually doesn't end until 3:30. So we have ample time. So hopefully y'all have allotted for that and you're all still hanging in there. I'm was chatting with Nikki on the side that we had 773 folks register for today's webinar and 444 attend. So we know and we've heard over the years that this is really important. And this, I believe, is our third webinar in partnership with the COE, and we will have more. So I'll get to that in a moment. But a couple slides just kind of drawing that bridge between what does this information that was shared today really mean for ombudsman programs, which again we'll build upon, but I wanted to share these two slides that just has some charts. I'm not going to read it all to you because you will get the slides after the presentation, and we put the link in the chat already. But the primary source for this information in this section is from Dr. Susan Weary, which many of you in our network may be familiar with. She is phenomenal. She's a geriatric psychiatrist and an advocate. She has provided trainings for NORC, Consumer Voice, and state ombudsman programs for years. So a while ago, a few years ago, we pulled from the trainings that she provided to develop this chart in one of our resources. And it illustrates the connections between the principles of those that work specifically with individuals with mental health disorders and ombudsman program principles. Brian walked you through how best to work with individuals with mental health disorders. And I'm sure, as you heard in his presentation, it closely aligns with the core values and principles of your work already. And the fact that your basic advocacy approach of resident direction, getting to know the residents, and empowerment, and letting them lead advocacy to the extent possible remains the same. But obviously, you may need some additional information and skill building and understanding mental health disorders, and especially in debunking those myths that Brian discussed earlier. So, this is why we're partnering with the COE, and we'll continue to build on this training. Next slide, please, Libby. So here's the second page of that chart, and then I linked in this slide our landing page for all of our resources that we currently have. So please visit that page if you haven't already. Next slide. So some key takeaways before we get into the discussion. Please sign up if you haven't already to receive the COE resources, and then share those resources as you go out and visit the facilities. Try your best to be proactive. You know what's going on in these facilities. You're on the ground, you're seeing what the residents need, you're identifying the trends. So please encourage providers to connect directly with the COE. One of our previous webinars with the COE went through all the resources they provide. They obviously provide these national free webinars, but they also provide individual facility support for free. They work with regional representatives that can train and provide detailed technical assistance to facilities. So be proactive, connect them as early as possible, and then share those best practices that you heard today with your program representatives and facility staff. Obviously, we want to maintain your role as an ombudsman. You're not the doer. You are the advocate for those that should be doing their job to do their job. So support residents by providing information, encourage residents to seek additional support. Obviously, you're following resident direction, so maybe they've disclosed to you feelings of depression or even suicidal ideation, but you need to follow their direction and identifying supports, reaching out to supports in the facility, and working with them and developing that trust and rapport to while they continue to talk to you. Follow your state program policies and procedures, of course, as well. Next slide. So talking about more support, because I just want to make sure that you understand that today is a first step in assisting ombudsman programs in understanding suicide prevention and response to when residents express suicidal ideation. We're not going to get into the weeds of that ombudsman role today. That is going to be in the future, and NORC is working on collecting policies, practices, and experiences from state ombudsmen and your representatives to inform the resource that we develop. So I put in our email address there. So if we have heard stories from representatives that they have heard from residents expressions of suicide, and they want to know how best to respond. And we are aware of a few states that do have some policies and procedures and trainings. So if you have those and you haven't shared those with us, please do. Or if you have a question or example, please share that as well. And by the end of our grant year, which is in the end of June, we will have a new resource and perhaps another training on this topic as well that digs a little deeper. Next slide. Okay, so with that, I want to get to our questions. We have a lot, so let me pull those up and we will get started. Thank you for your thoughtful questions. Just to let you know, if we don't get to all the questions today, that's why I ask you to put them in the Q&A. It's easier for us to keep track of them. We will do our best to address them in the future as I work with the COE to identify additional trainings. So the first question we have is there some evidence of a relationship with bipolar and or schizophrenia and autism?
Um, so those are the reality is the relationship between those things is probably murky. So I haven't, I'm not a researcher, haven't done a lot of research on it. What we see for all of these illnesses is there's a genetic predisposition, probably, but it's not 100%. The highest rate of genetic strength is schizophrenia, and identical twins raised apart, the rate of schizophrenia, if one twin has schizophrenia, the other twin having it is only 50%. So there's clearly some, but you'll see a family where somebody has anxiety and dad is an alcoholic and they have a child with depression. So there's some genetic relationship, but we're not really sure what it is. And I'll be honest, I wouldn't be surprised if in 100 years, what we currently call schizophrenia or what we currently call autism or bipolar disorder, even depression, ends up with kind of multiple actual illnesses. We're still in the dark ages when it comes to why this stuff happens in the brain and what's going on. I hope
Thanks,
that
Brian.
that was
Yeah,
clear as
no.
mud.
I think that's the best answer we have right now because
Yeah.
as you said, it's the mysteries of the brain. Speaking of further mysteries, what brings on mental illness? Is one not born with it? Is it hereditary? I know you talked about
Yeah.
a potential
So
link.
something like autism, you're probably born with, but we're still not really sure why people are born with autism. Um, Often what they talk about is a diathesis stress model. The model that's held up right now is like type 2 diabetes. You have a predisposition for it, and then you have a diet or encounters of things that make you developing type 2 diabetes more likely. So it's stress, but the question becomes, for instance, you might have developed mental illness regardless of what happened, and some people don't. So it is still unfortunately um, pretty murky.
Thank you. Let's see. When someone is schizophrenic, how does the person manage in the workforce if not on medication? What happens to those same people are in nursing facilities and you may not know he or she is schizophrenic?
So what I would say with schizophrenia, if somebody's suffering from schizophrenia, um, and they're not taking medication, they probably are going to have a psychotic break at some point. It tends to be a progressive illness. Each psychotic break, it makes things a little bit worse in the brain. Um, so if they're actually unmedicated in the workforce, we're probably going to see them have psychotic breaks, and that'll be in their history. Um, of course, if somebody's in a nursing home, the problem is that primarily we diagnose schizophrenia by looking at psychosis, and there's other factors that can um, look like psychosis. So I think to diagnose it in a nursing home, the doctor is really going to have to rule out some of the other things that could be going on, um, such as medication induced or dementia or something. So if somebody does have schizophrenia and they're not getting medication, unfortunately, the progression is each psychotic break tends to cause a reduction in functioning, and people don't always get back up to the level of functioning they had before the break. So it can be progressive.
Thank you. Could you address psychiatric services versus therapy services? Residents are more likely to have access to psych services, but those are often limited to med management. Residents seem to be unable to access talk therapy or face so many systemic insurance barriers they essentially have no access to mental to therapy.
Um, yeah, I think that's a real problem. I think it's up. We've got them there. We've got them on. Um, we've got them on medication, and nope, they're taken care of. I think it's a real problem. I think it's generated. How do we bill? What does the insurance billing look like? I think I wished it would just be part. It'd be nice to see as a mandatory part of services are provided. Of course, I would also like to see if the federal government were to mandate that the federal government would pay more in Medicaid and Medicare for those services as well, so that they can happen. I agree it's a real issue. Um, I don't have a good solution. I've been on kind of both sides of it, where I'm on the budget side and and I'm on the advocacy side, and it's difficult. I think it's very much needed. Um, and yeah, I think it's a hard problem to solve.
Agreed. And unfortunately, it's not just facilities, it's communities that lack of
Yes,
access to services. What suggestions do you have if we see, so ombudsmen are out in the field and they
right.
see facility staff respond in a way that escalates rather than de-escalating a resident? As another issue, we see some residents get blamed for a bad outcome like verbal threats or physical violence. How might you respond if a resident shared information that indicates a staff person's response escalated a problem? How would you attempt to help the facility see how they contributed to this outcome?
Well, I mean, ultimately, it's education, education, education. And so I think being able to talk to um, the people that will listen at the facility and say, this is the feedback I'm getting. Here are some suggestions that I have that, where we might be able to um, support your staff so that we don't have the escalations. And I might try to sell it in a way that this is how we want to help your staff. It doesn't do you any good if your staff are angry and escalating. It's not good. It's not good for the residents. It's not good for everybody. Here's how you can have a better optimum outcome. The ultimate reality is um, what we want with de-escalation is for it to be better for everybody. If there's a specific kind of scapegoat resident, I might want to sit down with them one-on-one and really probe and try to understand with the incidents what it is, what needs they had that weren't getting met. You might be able to uncover, as an outsider, you might be able to uncover what some hidden issue they've got going on that the facility has missed. And if that could be addressed, they might be less likely to act out. I always come back to with escalations. It is almost always that the person is not getting a need met. And if we could figure out what those needs are, if we can, and try to help them meet those needs, um, that we can avoid having the escalation in the first place.
Agreed. So I think just to recap what you said, because I think this is really, really important, going back to adequate training of direct care staff, everybody that interacts with residents on de-escalation strategies, but also, of course, emphasizing knowing the individual because part of their care plan, part of their assessment, triggers should be addressed, and successful ways to manage escalation should be addressed. And sometimes it doesn't work all the time. So again, going back to the drawing board and working with the individual resident to see what could be changed.
And Amity, if I could add quickly, I'm going to place the Center of Excellence for Behavioral Health and Nursing Facilities link. I placed our website in the chat, as well as I'm going to place our resource link in the chat. We have multiple resources created specifically for nursing facilities around de-escalation strategies, bite-sized learnings, modules, um, educational flyers, handouts that you can freely download. You can email to your nursing facility contacts. You can share those resources with them. make them aware of us and what resources we have available, because we definitely have some things that we've dedicated to de-escalation that could be helpful, for the nursing facilities and the residents, because it's very important. Thank you.
And SAMHSA's paid for it.
Yeah.
And CMS.
Yeah, yeah. So
Absolutely. I'm glad you dropped those links, because one of the other questions was about how can nursing homes train their staff on residents with mental health needs, behavioral health needs, and are there any classes? So great timing. Thank you very much. Let's see. I'm not sure if this is really a question that you can respond to or just more of a comment, but I do want you to hear it, and everybody else too. The barrier to care I routinely encounter is a person who's diagnosed with both Alzheimer's and mental illness. Our local mental health group refuses to see an individual even when their presentation of behaviors or unmet needs is primarily mental illness.
ooh. I'm not sure with some local mental health group, if that's like an outside organization or the people that's in the system. You know, I would argue that there's always room for, at the very least, with a mental health intervention, there's always room for cognitive restructuring. You know, somebody may be beyond kind of significant insight therapy, but in terms of restructuring, redirecting, um, psychosocial coaching, I think there's always room for those things. And I say that as somebody who worked as a case manager directly with people with schizophrenia and as a therapist who's worked with people with schizophrenia. We knew a whole lot of insight with a lot of those people. But there was always something that could be done. And frankly, taking an hour or taking 30 minutes, whatever the person can tolerate, to give them one-on-one engagement that's totally focused on them. I don't know. I can't help but help the person. So I'm Sandy. I'm sorry to see that. That really bothers me quite much as a therapist. I think those are mental health professionals that aren't really living up to what they should be.
Thank you. So it's a few minutes to closing, so I think we have time for at least one more question. What sort of resources exist for those with personality disorders? Um, and even beyond those, such as unspecified personality disorder?
Well, the biggest thing with personality disorders really is working with somebody with insight. You really want to work with a person with some insight therapy and restructuring. Unfortunately, when we look at um, like narcissistic personality disorders, they generally don't think there's a problem, so they don't want to engage. So it's difficult to get those people engaged. If somebody's antisocial, um, the key, again, my key is that what I want to do is teach them to be a better con. You can get ahead better if you play the game rather than fighting it. That works. When you look at people, kind of the big daddy with borderline personality, disorder, they're usually unhappy and want therapy and want to figure out and get engaged. But some sort of individual therapy, medication can help in terms of mood stability, so like a mood stabilizer. But really, that's either an individual group therapy, or even it's hard to do this if they're in a facility, but if they're outside of a facility, some sort of intensive outpatient treatment program can really help personality disorders.
Thank you so much, Brian. Um, all right, I'm going to squeeze in one last question.
Okay.
Just because I know that we've seen some situations fairly recently about this. Can you address suicide pacts between spouses or life partners?
So I think this really does speak to the fact that older people are likely to tell no one, and have use lethal means. And you know what? Often what's going on is somebody is not doing well. They know they're not do. They don't want to be separated. We've lived our entire lives together. You know what? And they're making a very conscious decision about what they're going to do in the future. And it's really kind of difficult. It's really going to be kind of difficult to stop that from happening if they've really made the decision to do it. And they don't tell anybody. The reality is, if somebody's bent on killing themselves, there's nothing we can do to stop them. And those are often people are they are dead set on making it happen.
Thank you, Brian. That's why I think it's so important that we talked about the signs and anything that we could do to prevent it getting to that point. And of course, with the Ombudsman program, we're not mandatory reporters, cannot be mandatory reporters, and have strict federal confidentiality and disclosure requirements. So that's why we will continue to talk about how to respond once you hear that
Mhm.
someone has suicidal ideation in the future. So thank you, Brian. I'm going to go ahead and go to the next slide, Libby. And thank you, Nikki. All right. So not to switch gears too much, but since I have so many folks on the line, just wanted to share that the COE will be presenting during the Consumer Voice Conference, which is coming up here in just a few days in San Francisco. So if you are interested in joining the CV conference, and registration is closed in person, but you can still register virtually. There are a lot of sessions specifically for ombudsman programs to build skills and your knowledge base. Next slide. If you did not receive information about this webinar directly, maybe you got it from your state ombudsman, your supervisor, or colleague, that means you may not be on our email list. So please click that link, or Libby or Katie, could you drop that link in the chat, and folks sign up for our email list so we can send you all of our webinar information and resources and more. Next slide. So I know that you had the survey and the post survey that was specific for our speakers and for COE um, for their reference about your knowledge before and after the training, but we always provide an evaluation too, because we want to know from you what you thought about the webinar and what you want to hear more about in the future. So please, as soon as this webinar closes out, a link for SurveyMonkey will pop up. And if you could just take a brief couple minutes and fill that out, we would really appreciate it. Next slide. So as I mentioned earlier, if we did not get to your questions, or maybe you put a question or comment in the chat and we didn't see it, we are copying all that information, and I will work directly with Nikki to talk about future webinars. So we will get to as much as we can and continue to share from this amazing resource. We are so glad that SAMHSA and CMS is funding the COE and that we are able to participate in the training. So thank you. Thank you, Brian. Thank you, Nikki, for sharing this very important information with us and for partnering with us again. Thanks, Libby and Katie, for assisting with the webinar behind the scenes. I really appreciate it and couldn't do it without you. And of course, thank you all for doing the visits you do, the advocacy you do, and for attending and sharing your really thoughtful questions and comments. So please, we'll continue to do this work, and let us know what you think in the evaluation, and look forward to talking to you again soon. Thank you so much. Have a good
Thank
rest of your
you.
day.
Thank you, Amity.